you'll recall a week or so ago, we did a first part of this on the scrutiny the program is under and some arrangements that are coming to light that are causing some issues. And so now we want to transition to more the compliance oversight within the entity that is the covered 340B entity. So the one challenge I really want to point out is that if you're looking only at complying with the 340B regulations, that's all you're looking at. And there are just a lot of issues adjacent to 340B compliance. So it's more, in other words, it's more than just worrying about your HRSA audit. That's the regulatory body that audits this program. And so you have consultants looking at and saying, we will help you implement and we'll help you with your 340B oversight. You need to understand they are looking only pretty much the 340B regulations, which there really aren't that many of compared to some other programs. So it's important that healthcare providers realize the areas that are adjacent to the 340B program that could crop up and address those issues as well. The adjacent issues that can crop up that you need to be wary of are the False Claims Act, the Anti-Kickback Statute can arise, state provider licensure laws, beneficiary inducement prohibitions, Medicare cost reporting issues, provider-based rules. There are also federal and state pharmacy and wholesale laws that could come up, and as well as privacy laws. So often I find it's helpful not just to list all of those statutes or regulations it could provide, but to give you some examples so you'll have them in your head when you see them and recognize them. Just take, for example, the Anti-Kickback Statute. Things that may cause problems with 340B implementation in the anti-kickback arena could be arrangements in which a vendor receives compensation based on net revenues of the 340B program. Another example is if a contract pharmacy has dispensing fees that are either below or above fair market value. A third example under the anti-kickback could be joint venture type arrangements where the pharmacy or the 340B entity's contribution is patient referrals. Anything that addresses any of those should raise red flags under the anti-kickback statute. Under the False Claims Act, some examples are submitting state Medicaid claims in excess of the 340B actual acquisition cost, which is required, or reporting incorrect disproportionate share hospital information on your cost report in order to become eligible for the 340B program. That would raise issues as well. Another example under the patient inducement context would be if a provider is providing services or at no cost or below cost to patients in order to get them to be a relationship or establish a relationship for 340B. Another example is providing additional services without cost to patients if they fill prescriptions at your pharmacy. So any benefit to induce their business can also raise issues. Yes, these laws outside of the 340B program, if your 340B program is audited by HRSA, you're going to have regulatory penalties, or you're going to have to correct or submit a corrective action plan. All these other statutes that you could violate have, frankly, more severe consequences as far as penalties and the possible negative ramifications. One tip is don't just make compliance or oversight of the 340B program the pharmacy department's issue. Because one, your pharmacy department usually doesn't have authority over anyone else to hold them accountable. And like we just went over, there are a lot of adjacent issues, compliance, statutory, regulatory issues that your pharmacy department will have no idea about. So you really need to put together a team, your compliance, your legal, if you have those in-house resources, and if you don't, you may need to call us, get us assistance, or be aware that those other adjacent issues may be as significant as compliance with the 340B regs.